aged 20 to 50 years, it has no sex predilection, and it is usually detected during routine x-rays in developed countries, but however in areas like Namibia, which is a developing country, patients usually present late, and they usually present with massive facial swellings leading to delayed treatment and causing facial disfigurement and social distress. So for classification of the tumors, the World Health Organization classifies tumors into 4 types, which is the conventional or multicystic, could be unicystic, peripheral, or desmoplastic. With conventional or the multicystic, it usually presents as follows in the radiograph, as you can see, as multilocular radiolucencies of the radiograph. It is also the most common type of ameloblastoma that we usually encounter. Then unicystic ones usually present with a unilocular radiolucency, and the peripheral ones usually are in the soft tissues or in gingival tissues, so they rarely affect the bone. And then for desmoplastic, they usually occur in mixed, so it's a mixed multicystic and unicystic.
Just before you go there, because it's also teaching, right? So when you say multicystic, okay, on that image on your right, can you show us so that everyone can understand what you mean by that? Yeah.
So multicystic, as you can see, here is a radiopacity, here is another radiopacity, here is another one. So it's multiple cysts together, evident. And then on this one here, we just see one unilocular image. So it's not multiple, it's just one.
Thank you.
And then for clinical features, as you can see in the image presented here, patients present in the 3rd and 5th decade with painless swelling. So pain is rare because it is a benign tumor. So the patients usually stay at home because there's no pain. They come into the clinic with huge swellings on either side of the face. There is usually lingual and buccal cortical bone expansion. So because of the effect on the bone, there is usually also root resorption in the adjacent teeth. So in this case, since the swelling is in this area, the bone in this area, the mandible can be affected, which would cause the teeth in that exact area to be affected as well. Since the teeth are supported by the bone, when that bone support is lost, the teeth become mobile. So that would cause mobility of tooth, it would cause malocclusions. And then in advanced cases where the patient has been at home, the lesion has been there for several years, may become secondarily infected, and then this is when patients present with pain. So when they present with pain, it means the lesion is secondarily infected, and then we may also encounter crepitation or eggshell crackling on palpation in the large tumors due to destruction of the bone in the area. So advanced complications, as I said, would be massive growth, which causes severe functional issues, altered bite, loose teeth, localized numbness, because obviously the nerves in the area are also become affected, and in some cases, severe airway obstruction, because the lesions are usually located in the mandible, so it in close proximity to the cervical region. So when the swelling extends to the neck area or submandibularly, it may cause airway obstruction. Then moving on to our radiographic features, as I explained earlier, the ameloblastoma typically presents with a honeycomb appearance. So it's this thing here. So it's like a soap bubble. You know when you put soap in water and it makes a foam, those bubbles that foam, this is what it would present like. This is the most common presentation. So majority of them appear like that. As I said, some of them appear unilocular. And then these lesions are also usually associated with unerupted teeth. So you would find an unerupted tooth in the radiolucent area. And then as I explained earlier, do you see how the bone here is affected? So the teeth here have no longer have support, so the roots have resorbed, meaning they have decreased in length, they have shortened now. It's not like the other roots on this side that are long all the way up to this area. You can see this one become a bit shorter. This is called root resorption, and it's because of the effect on the bone. So the roots are also affected. So when this is the case, the tooth becomes mobile, there's no longer support in the area. Usually there is also irregular swallowing of margins in the radial lucency. There is thinning and expansion of the macro and lingual-cortical plates in large tumors, and sometimes teeth may also become displaced. So when they become loose and the swelling continues to grow, you will find that the tooth is no longer where it was supposed to be. It has now moved with the growth inside the mouth. So it's no longer here, it's just displaced within the tumor. For differential diagnosis on imaging, like the previous x-rays, ameloblastoma usually tends to resemble odontogenic keratocyst, dentigerous cyst, and sometimes central giant cell granuloma. So usually histology is the best way to find a definitive diagnosis. And then moving on to management. Management can be classified into either conservative or radical. So conservative is usually indicated in lesions that are detected early or lesions that have not affected the bone as much, smaller lesions. So in this treatment, we conserve as much of the jawbone and tissue as possible while trying to remove the tumor. So examples include enucleation, curettage, cryotherapy, because these lesions have not completely invaded the entire bone. There is, however, high recurrence risk because we are just removing we are removing the tumor in its entirety, but we are not considering the safe margins because we are trying to preserve tissue and bone structure. And then with radical or surgical treatment, it's usually indicated in long-standing tumors, the tumors that have invaded a lot of the bone. So this is where we remove the tumor in its entirety with 1 to 6 centimeters of healthy tissue or bone, just to reduce recurrence risk. So that's why we find that surgical treatment usually has low recurrence risk as compared to conservative. Examples include marginal resection, partial mandibulectomy. So usually, if the ameloblastoma is in the mandible, we take the patient to theater and we remove the entire mandible. Or we can remove part of the mandible depending on which side is affected, including a margin of healthy tissues or healthy bone. Most of the time, it's the mandible involved. So we have seen many cases where we remove the entire mandible and the patient is left without a mandible and they have to live like that for the rest of their lives. So what we are trying to emphasize as health professionals, I think it's important that we detect these lesions early on and we do timely referrals, because patients sometimes have been at home for 15 plus years. They probably went to the clinic complaining of a cough, they were given paracetamol and some cough medication, but they do have a lesion and it's there and nothing is being done. Because I don't think a person can stay 15 plus years without ever visiting a health center, except if they are probably in areas where they don't have access to healthcare. But these are people that are here in Rundu, not elsewhere. In our town in Rundu, there are several clinics here. We have a state hospital. This is a referral hospital. People refer patients to here. So, and we are seeing a lot of these cases in areas where there is access to health facilities. So what we are trying to emphasize is that when you do encounter patients like this, examine the patient and just refer the patient accordingly. Just because it's not in pain or anything does not mean we should ignore the problem, because then later it becomes life altering, because this tumors cause severe facial deformities. So they affect the quality of life. The patient is no longer able to eat properly, to chew properly. Social interaction is no longer up to standard, if I should say so, because you now have this huge facial deformity on your face and there's nothing you can do about it, because this is the only way to keep you alive. If you do not remove the tumor, it could progress and cause other difficult problems. So we really pleading with everybody, when you encounter, even if it's a small lesion, the patient is not aware, and you see there's a swelling somewhere, it does not have to be the mandible, it could be anywhere in the head and neck region. If you are not sure what it is, you could always refer to our dental department who do deal with head and neck regions. So now my colleague Dr. Adai will be presenting on a case that was managed here in the Immediate Hospital by our doctors, our dental team, and our specialist, Dr. Prentice. It was a case of Ameloblastoma in the mandible, and she will take us through how the case was managed.
Okay, I'm going to ask something about the treatment. The radical treatment. Some of the cases we cannot do anything because of the morbidities they have. But in other case, young patient, if we have all the recommendations, the hospital plate, screw, and some specialty that we can do bone graft from the iliac crest, scalpel, ribs, and fibula. We can do also flap, that supraclavicular flap or pectorally major flap. One of them we did with the case we are going to present now. So we can, after that, we can reconstruct the patient with implant, and the prosthodontist can do the prosthesis, and the patient can run your life fine without any psychological affectation. So, but in all of our case, sometimes we don't have all the conditions, but we are going to try to do it better. We having many specialties now, and I know we can do one case with bone graft reconstruction. Thank you.
While we are still setting up, there was a point where we had differentials for growth in that area of the mandible. And I think Dr. Siwongo mentioned that probably histology will give us a definitive diagnosis. So my question probably for the team to highlight more is any role for preoperative biopsy to get a histological diagnosis?
Yeah.
It's something that did not come out. Probably you can comment on that.
Yeah, we used to do first biopsy because there are many differential diagnoses. Even this condition can be like it's a long period, can be ameloblastoma carcinoma. So we have to differentiate first doing preoperatory biopsy before to do the conservative or radical treatment. We have to plan first which condition is this to plan our surgical treatment.
So if I understand you correctly, is you have to do the biopsy to determine if it's a carcinoma, if it's or just a non-cancerous.
Yes.
Yeah, depending of the biopsy is the plan, the treatment plan.
Yeah.
Good morning, everyone. I'm Dr. Adai, and I'll be presenting on the case of a patient who was treated at this hospital in June last year. So the patient is a 27-year-old female who presented to the dental clinic with complaints of a massive surgery on the right side of her face and neck. So the patient reported that she has had this swelling for over 10 years, and it caused her significant facial deformity. And she reported to have suffered from pain, infections, occasional oral obstruction, and difficulty eating and chewing. So the patient reported that prior to presenting to the Immediate Hospital, she sought treatment at Katakura State Hospital's maxillofacial department, where an incisional biopsy was done and a diagnosis of ameloblastoma was established. The patient's medical history revealed that she was on antiretroviral treatment and she was also anemic. So when she presented to our clinic last year, we did a thorough examination, and on extraoral examination of the patient, there was marked facial asymmetry present due to a swelling on the right side of the face, involving the parotid, the zygomatic, the buccal, the mesenteric, as well as the right half of the mandible, and then the submandibular and the upper right cervical regions were also involved. On palpation of the swelling, it was tender, it was firm, however, it was non-pulsatile, it was non-compressible, and then the overlying skin of the swelling had a shiny appearance, and the swelling also caused displacement of the higher bone to the left side. This is a more up-close image of the swelling, which shows the extent and distribution.
The MICT column.
On intraoral examination, there was a large oval mass extending from the right ascending ramus of the mandible all the way to the midline. So there was severe displacement of the tongue in its associated structures, as well as the oropharynx to the left side. And there was visible expansion of both buccal and lingual cortical plates, which would appear as significant or as severe enlargement of the gingiva. And then on top of the lesion, on top of the tumor, there were traumatic ulcerations present due to occlusion from the upper teeth. And on palpation of the tumor, there was pus and fluid discharge observed. And lastly, there was a significant shift of the upper right segment to the left, as well as generalized mobility or movement of all the teeth involved in that region. The investigations carried out in managing our patient include the pre-referral biopsy, which was done at Kapukura Hospital's maxillofacial department. That confirmed it to be conventional multicystic ameloblastoma. And the histopathological report revealed that it was a very aggressive tumor, though non-cancerous, as it had mixed growth patterns, which included follicular, reticular, and acanthomatous growth patterns. When she came to this hospital, we did a CT scan of her head and neck. This image is was part of the report from the CT. So the findings of the CT were that there was a large tumor, which was the size of a tennis ball on the right lower side of her jaw. And then the tumor was filled with multiple compartments or pockets, which were separated by internal walls, as shown in the image here. So these pockets contained a mixture of air and fluid instead of solid bone as you'd expect. There was calcification of the bones, and as we can see, this entire part had been destroyed. And then there was shifting of the mouth due to the massive size of the tumor. And there was also compression of the blood vessels in the involved regions, which caused them to change in shape. These are CT scan images which show the extent and the distribution of the tumor. On to the treatment done. So before anything was done to the patient, we did a thorough pre-op assessment and preparation. So we did our clinical examination, established the diagnosis, and then the patient was admitted to high care ward on cefuroxime, hydrocortisone, multivitamins, and lampinates in preparation for surgery. We also ordered a full blood test. That was the FBC, the UNE, and the CRP, just as a routine measure. And cross-matching was done because we stated that the patient was anemic. The procedure was explained to the patient, the risks and the benefits, and the post-op plan was also explained to her. She gave consent for the procedure to be done, and then she was assessed by the anesthesiology team. And lastly, we did stabilization of the jaw by attaching the lower part of the jaw to the upper chest so the mouth is locked, so that after surgery, there's no deviation of the midline. So in theater, a hemimandibulectomy and supraclavicular flap reconstruction was done, along with removal of the tumor. It was done under general anesthesia, and nasotracheal intubation was performed. So these are just the margins or the markings where the incisions were to be made in order to access the tumor. As we can see, one was made here in the region below the ear, and below the right angle of the mandible, and there was also one made along the midline of the lip and the chin. Okay, so in order to access the tumor, a lip splitting incision that extended all the way into the head was made. The tumor was accessed and it was completely removed, so there's complete resection of the tumor. And then the entire diseased part of the right mandible was removed, that is the hemimandibulectomy, as well as the top part of the jaw joint, which is the condylar process, as the tumor had affected that bone. And then the first image on the left is the image after, that is the image after the tumor was removed. So that is how the skin inside looked. And this is just an image of the tumor after complete removal. You can see it was quite huge and rubbery on palpation.
So Doc, why in that picture, why do you have a 20 ml syringe next to the tumor? What was the point?
Used to measure the length of the tumor.
So what's the estimate? It's asked for us to tell.
What is coming?
You don't remember, you don't know.
No, since you are already there,
Yeah.
you don't need to repeat it when you come. So can you just hear that?
So,
Or you can't remember.
it's coming.
You know in the exam, you don't say it's coming late. Because this is the preparation for exam.
Yeah,
And in the
yeah.
exam, you don't say the exam. You don't tell the examiner it's coming. It's either you say, I can't go, I'll refer to the next slide. You just prepare it. Okay.
Okay, so after the tumor was removed and the infected part of the mandible, tissue reconstruction was done because the defect, the tumor in the infected mandible left a huge defect on the floor of the mouth and in the right cheek. So a flap was raised from the right supraclavicular shoulder region of the shoulder, and the healthy tissue was tunneled under the neck and stitched to the opening. But there was no damage of the attached blood vessels and there was adequate blood flow in the region. And suturing or stitching was done using nylon sutures in order to achieve a complete sealing and rebuilding of the floor of the mouth. This is the patient immediately post after surgery. As we can see, there was a nice closure achieved, and a suction was placed inside the neck just for removal of excess fluid. Okay, this is another image of the patient immediately post-op. And on to the post-op care, the patient was transferred back to a high care ward for observation and recovery. And then pain medication was prescribed, antibiotics were also prescribed. So to be specific, paracetamol was given for management of pain. And then the antibiotics prescribed were ceftriaxone and metronidazole. Midazolam as well as morphine were also prescribed, and then dexamethasone and omeprazole were prescribed. And then the patient was closely monitored in intensive care unit